Hi, I'm Annie, a resident at Nepean Hospital, currently doing a neurology term. So I thought this would be a good time to help create a lecture on the topic Approach to Weakness/Slurred Speech. It will just be a broad overview today with hopefully some more practical information on how strokes, particularly acute ischemic strokes, are assessed and managed in an in-hospital setting. And hopefully this will supplement your clinical learning in this difficult time. My lecture will focus on general assessment of a patient who presents with new neurological symptoms, a little bit about the acute management, and then some subacute management information. I'll be using a hypothetical case study patient today to help guide the lecture as well. So to begin, just some general epidemiological factors about stroke in Australia. There is one stroke every 10 minutes in Australia, and more than 80% of strokes can be prevented with risk factor modification. About 30% of strokes occur in people of working age, that's less than 65 years of age. There appears to be a common misconception that strokes only affect the elderly, and strokes can cost the Australian healthcare system about $15 billion a year. Most strokes are ischemic, 85%, versus hemorrhagic, 15%, which is why we're going to focus on ischemic strokes. And just another fun fact, stroke actually kills more people than breast cancer for women in Australia and prostate cancer for men. So our case study is a 78-year-old lady who presents to the emergency department with right-sided weakness and difficulty speaking. She's obviously looking a lot more worse for wear than our little cartoon lady there. So in this situation, a stroke cord will most likely be called. This can be done by the ED triage nurse or some of the ED doctors. At Nepean Hospital, stroke codes are only called in business hours. Out of business hours, if it's on the ward, it's a MET call, and if the patient presents to ED, it's just managed by the ED doctors. But in some hospitals, there's a 24-hour stroke service. So strokes are a medical emergency. Millions of neurons die every minute in patients who've had a stroke. So the quicker this can be stopped, the better the outcomes are for the patient. To help try and speed the process up, there's kind of a public health campaign talking about fast positive. You'll sometimes also hear this being used by paramedics or triage nurses and even some doctors. And it just reminds the public that if a patient has facial droop, if they've got arm involvement, if they can't lift both their arms, if they have speech impairment, either slurring speech or understanding of speech, then you have to act fast. And in the community, it is an emergency, so you should call 000. So when these patients do come to a hospital, the stroke code is activated, and that usually involves a stroke consultant who's on call, and a stroke registrar or a neurology advanced trainee who's on site, as well as it could be a stroke nurse and like neurology registrars and JMOs. And the purpose of a stroke code is to expedite the workup of stroke patients who may benefit from acute reperfusion therapy. So that's either IV thrombolysis or endovascular thrombectomy or endovascular Quat retrieval, which we'll talk a little bit about later. So after the stroke code is called, the stroke team should arrive very shortly, and they perform a rapid initial assessment. And that's to look for information that supports the diagnosis of a stroke, but also helps consider other differentials. So they begin with a brief history, and important things that they ask is time of onset or last known well. Timing is the most important factor, as it is a key determining factor in whether a patient can receive thrombolysis. Strokes also have an acute onset of symptoms. If the onset is gradual, you can consider other causes. In terms of signs, symptoms, or deficits, it's really important to figure out which side the patient's having deficits on, what associated changes do they have, and have they been well recently. In terms of past medical history, important things to ask about are if the patient has had any previous cardiovascular events, but also do they have a previous history of any other neurological conditions? Do they have a history of seizures or migraines, any malignancies? You should also ask about risk factors for stroke. Importantly, things like atrial fibrillation, hypertension, high cholesterol, diabetes, and smoking. In terms of medications, what you really want to know is, are they on any antiplatelets or any anticoagulation? But also a medication list can give you a kind of a good broad past medical history or current medical issues the patient also has. Other things you need to ask about are what the patient's baseline function is, because if the patient is independent from home versus if they're bedbound from a nursing home, that can affect whether or not what kind of treatment they get. So after the history is taken, we perform an examination. So this can be also done concurrently when another member is taking the history. And for the examination at a stroke code or in an acute stroke situation, it's different to the full neurological examination you read about in Tally and O'Connor, and it's an abridged version called the Nist Score, and that stands for the National Institutes of Health Stroke Scale, and it helps objectively quantify the impairment caused by a stroke. So the Nist Score is listed below. A Nist Score of 0, the stroke, either the patient has no stroke or might have had a TIA. A Nist Score of 0 to 4 could correlate to a minor stroke, 5 to 15 moderate, 16 to 20 moderate to severe, and 21 to 42 a severe stroke. It's important to remember that patients who haven't had a stroke can also have a Nist Score greater than 0, and a Nist Score is not a diagnostic tool, rather it allows for rapid neurological examination of a patient in an acute situation, and then it can help us communicate quickly how severe the deficits of the stroke are with a numerical score, kind of like a GCS score or the Glasgow Coma Scale. So how do we actually get a Nist score? The domains of Nist tests are level of consciousness, orientation, ability to follow commands, extraocular movements, visual fields, facial palsy, upper and lower limb drift, ataxia, sensation, speech, and inattention. And the idea of the Nist score is to be able to do it quickly. You don't need a lot of equipment to do it, tendon hammers or anything, and you can do it whilst a lot of other things are happening with the patient, and the patient can be triaged and then wheeled to imaging as quickly as possible. For more information on how you can conduct the Nist score, you can look on websites such as MD Calc, and it can give you more detailed instructions about how exactly to perform it. So even in patients that you are suspecting of a stroke, you should also consider what differentials could also cause this. Differentials include seizures with post-ictal paralysis or TOS paresis, metabolic disturbances such as hypoglycemia, any brain tumors, infections, cerebral abscesses, or even sepsis, or complex migraines. But stroke is the most time-critical and hence essential to rule out, particularly in high-risk groups, so people with significant amount of risk factors. So the case study continued. We got a collateral history from the daughter. She found her mom suddenly 3 hours ago, collapsed onto the sofa. Her mom was unable to get her words out, confused. She noticed maybe a mild right-sided facial droop, and she noticed she also could not lift her right arm. In terms of relevant past medical history, her mom has hypertension as well as type 2 diabetes, but that's controlled with oral hypoglycemics, metformin, and the only other medication her mom is on is perindopril for her blood pressure. Her mom had, on examination, the patient had a Nist score of 12, scoring points for the facial droop, the aphasia, the right-sided drift, as well as some sensory changes and possible neglect. So the most important investigation after your history and examination is for the patient to get a CT scan. And you need to get the full stroke workup scans, which include the CT brain, the CT angiogram from arch to cow, and a CT perfusion study. Signs of ischemic stroke on non-contrast CT brain. You can see a loss of an insular ribbon, loss of gray-white matter differentiation, and sulcal effacement. You can see that to the image on your left, and as well as a hyperdense sign, which you can see by the red arrow. So on the CT angiogram, arch of aorta to tau, the circle of Willis, you're looking for large vessel occlusion or stenosis, and you're looking to see if you can visualize any clots or filling defects. On the CT perfusion scan, you're looking for the ischemic core versus the ischemic penumbra. The ischemic core is non-salvageable or already dead brain tissue, and the penumbra is a surrounding area around the infarct core that contains brain tissue that, if reperfused as soon as possible, is possibly salvageable. So just some practical tips for a JMO during a stroke code. You need to put in an IVC, ideally a 20 gauge in the cubital fossa, and you need to collect bloods, importantly a full blood count, EUC, CMP, coags, and a VBG. You order the CT brain, CT angiogram, Ushikow, and CT perfusion. And sometimes it's really helpful, again, as I mentioned previously, to take a collateral history, whether it be from other family members, or you can call the GP and ask for a full medications list and past medical history. So the case study continued. On the CT brain angio perfusion, our 78-year-old lady had a possible acute left MCA ischemic infarct, and there was a significant penumbra on the perfusion scan. She was discussed with neurointervention as well as a neurologist. Neurointervention's opinion was that she was not amenable for clot retrieval. However, the neurologist said that she was for thrombolysis. The next couple of slides will talk about how they came to this decision. So the immediate treatment for acute ischemic stroke is acute reperfusion therapy, and this takes two forms, either thrombolysis or endovascular clot retrieval. Patients can have both or one or the other. And the goal of acute reperfusion therapy is to remove the thrombus blocking the blood vessel, allowing for successful reperfusion of any salvageable brain tissue or the penumbra on the perfusion scan. Thrombolysis is performed with a tissue plasminogen activator named alteplase. So how did the neurologist come up with the decision that this patient was for thrombolysis? Well, below in the table lists the inclusion and exclusion criteria for thrombolysis. So the inclusion criteria is a clinical diagnosis of an ischemic stroke leading to measurable neurological deficits. So a measurable neurological deficit or a significant deficit include things like hemianopia or any visual changes, severe aphasia, visual or sensory extinction, or weakness limiting sustained effort against gravity, or pretty much a Nist Score greater than 5. And these things are listed because these signs and symptoms most greatly affect a patient's ability to perform their tasks of daily living and their quality of life. It's also important to note that it is a clinical diagnosis of ischemic stroke is enough. So even if a patient does not have radiological evidence of an ischemic stroke, if they have enough, if the clinical suspicion is high enough, they can still be for thrombolysis. Also, another important inclusion criteria we discussed previously is onset of symptoms, and onset of symptoms less than 4.5 hours, or 4.5 hours since they were last seen well. Other exclusion criteria, there's a whole list on the next slide which you can read through in your own time, but ones that we encounter frequently are if the patient is on anticoagulation, so if they anticoagulate for AF or DVTs and PEs, they are not eligible for thrombolysis, particularly if they're on warfarin and their INR is greater than 1.7. If the patient has had a history of stroke or head trauma in the prior 3 months, if they have prior intracerebral hemorrhage or major surgery in the last 14 days. And this is because the risk of thrombolysis is bleeding, and you want to make sure that the patient does not have life-threatening bleeding, so intracerebrally or intra-abdominally. Other things that you can encounter commonly are long bone fractures. So patients who have strokes had a fall and unfortunately fractured something, they will also not be eligible for thrombolysis. It's also important to note that some of these exclusion criteria, not all of them are hard and fast absolute contraindications, and it is a discussion with your seniors, so the neurologist, and as well as the families about the risk versus benefit of thrombolysis. So as mentioned, this is a slide with some more detailed exclusion criteria for thrombolysis. So just a little bit about endovascular clot retrieval. ECR is only performed in a few sites in New South Wales. So it's not performed, unfortunately, at Nepean, but our closest site, or the site we sent most patients to, would be Liverpool Hospital. And on your right-hand side, you can see the neurointervention or the ECR pathway that we use at Nepean. So if a large vessel occlusion is highly suspected or identified on CTA, there is a number you call, which is a 1-800 4-stroke number, and then you'll be put through to a neurointervention on-call who usually is able to review the imaging off-site and tell you from their perspective if the patient is suitable for clot retrieval. Some eligibility criteria for clot retrieval include large vessel occlusions seen on CTA, usually in the so large vessels including the ICA, the MCA, but only M1 or early M2 or the basilar artery. And the patients usually have to have pretty good pre-morbid function. And in terms of endovascular clot retrieval, thrombolysis is less than 4.5 hours, but studies have shown a benefit for thrombectomy or ECR up to 24 hours after time of symptom onset or last known well. So after the immediate management, so either the patient receives a form of acute reperfusion therapy, or even if they don't and they're not eligible for thrombolysis or ECR, patients who've had a stroke are transferred to a dedicated stroke unit where they can receive post-stroke acute care. Important things that are monitored in the stroke unit are a swallowing assessment. So patients can be SIP screened, so they can be asked to drink a glass of water. If they do not have dysphagia, dysarthria, or facial droop, if they do have any of the above or they fail their SIP screen, they are to remain nil by mouth until a formal speech pathologist review. These patients also can receive intravenous fluids, particularly if they're nil by mouth, and you want to use an isotonic fluid such as saline or Hartmann's. You want to avoid hypotonic fluids, which may exacerbate cerebral edema, and you want to avoid fluids with glucose, which may exacerbate hyperglycemia. Also want to monitor patients for possible fevers, because fevers have been associated with unfavorable outcomes in a stroke. You can give these patients some Panadol. You also want to make these patients have good glycemic control. You want to avoid severe hyperglycemia in post-stroke patients. You also want to avoid hypoglycemia because hypoglycemia may mimic stroke symptoms, and you don't want any confounding examination findings, particularly in a post-stroke patient. After the acute phase is over, the focus then shifts to secondary prevention of stroke, and the pillar of that is antiplatelet therapy. So long-term antiplatelet therapy, aspirin, clopidogrel, prasugrel, should be prescribed to all people with TIA, such as ischemic strokes, who are not already on anticoagulation, and this is for secondary stroke prevention. In high-risk patients with minor ischemic strokes or TIAs, there is some evidence for dual antiplatelet therapy, which may be used in the first 3 weeks to prevent recurrence, and it is important to start antiplatelet therapy within the first 24 hours of onset of stroke symptoms if the CT or MRI scans exclude hemorrhage, unless the patient has been thrombolyzed. Other pharmacological management for secondary prevention is high-dose statin therapy using something like atorvastatin. Atorvastatin or statins have both a lipid-lowering effect as well as the effect for stabilization of any atherosclerotic plaques, and thus reducing the risk of embolus leading to strokes. Also important to manage the patient's hypertension. So there's something called permissive hypertension in the first 24 hours of ischemic strokes. Most patients who have strokes are actually hypertensive at the time of presentation and then subsequently experience a spontaneous decline in blood pressure. You don't want to decrease the patient's blood pressure too much in the first 24 hours because that will reduce the amount of blood flow that is perfusing the brain. In patients who are non-thrombolyzed, you can allow for a systolic blood pressure less than 220 in the first 24 hours. In thrombolyzed patients, however, you want to aim for a systolic blood pressure less than 180. After 24 to 48 hours, you can start antihypertensive medications if needed. But this definitely should be discussed with a neurologist. In terms of the subacute stroke workup, looking for risk factors that can be modified or causes of the stroke. In terms of bloods, you would do fasting lipids, fasting glucose, and a HbA1c, looking for hyperlipidemia or diabetes. And all patients should have telemetry either as an inpatient with like usually 48 hours of telemetry in the stroke unit, or an outpatient Holter monitor, and that's looking for atrial fibrillation. Patients also really need to have carotid imaging. So sometimes this is, or the carotid is already well visualized on the CT angiogram, but otherwise they can have carotid Dopplers. If a patient has greater than 70% carotid artery stenosis on the side, the appropriate side, so the side that corresponds to their stroke and their symptoms, they should be referred to vascular surgeons as soon as possible for consideration of a carotid endarterectomy. Other imaging they would have would be a thoracic echocardiogram or a TTE. This is looking for an embolic source of the stroke, so such as an apical thrombus, or if the patient has a dilated left atrium, it could be they could have had paroxysmal AF, or they could just be a sign that they have atrial fibrillation, or whether or not the patient may have a PFO or patent foramen ovale, and the clot is traveling from the right side of the heart to the left side of the heart, and then subsequently causing a stroke. So just to wrap up the case study, so after thrombolysis, the patient's Nist score was 2. She had her CT brain was done 24 hours after thrombolysis, which is routine. And that's to look for any hemorrhagic transformation, which she had none of. Her telemetry did not show any atrial fibrillation. Her TTE showed no significant embolic source. Her CT angiogram, which was done previously, did not show any significant stenosis of a carotid artery, so no stenosis greater than 70%, so no carotid Dopplers needed to be done. She did, however, have elevated fasting lipids. Her HbA1c was also elevated at 7.2. She was commenced on aspirin, a high-dose atorvastatin. She had regular BGL and BP monitoring and optimization. She was then reviewed by the allied health team, which include the physiotherapist, the occupational therapist, the speech pathologist, and she was able to be discharged with neurology follow-up. So this is obviously a hypothetical case, and it's slightly simplified, but I hope it gives you a good idea of a typical stroke patient's journey through hospital. So in summary, in a patient who presents with focal neurological signs such as weakness, focal weakness or slurred speech, in terms of the history and examination, you want to focus importantly on time of onset of symptoms. Are they within the thrombolysis or ECR windows? What risk factors does the patient have for stroke? And what their Nist examination or their Nist score is, what deficits do they have and how significant or severe are they? You want to get them to CT imaging as soon as possible. You want to do a CT brain, CT angiogram, CT perfusion scan, looking for any signs of ischemic strokes. If there's signs of ischemic strokes on imaging, or even if the clinical suspicion is high enough, and the patient is within the correct windows, they may be eligible for acute reperfusion therapy, which takes the form of TPA and or ECR, particularly if the clot can be visualized on imaging. After the acute phase of stroke management, you want to focus on secondary prevention and risk factor modification, and that's with things like antiplatelet therapy, statin therapy, making sure their diabetes and blood pressure is well controlled. So thanks, guys, for taking the time to listen to this lecture, and I hope you guys have learned something from this. Just an appendix, the next 2 slides discuss the common stroke syndromes patients can present with. It's important to understand the main presenting signs and symptoms of different stroke syndromes, because it can help you narrow the area of focus when you're viewing the imaging. It can also help broaden your differentials when the signs and symptoms of the patient presents doesn't really make sense. I'll let you guys read through the slides in your own time.